我现在可以开始了吗？贵宾平安。研讨会
Distinguished guests,
2分钟之后开始。
the conference will start in 2 minutes. We would like to remind you, if you want to apply for the credits, please scan the QR code to sign in and sign out. The organizer has provided simultaneous interpretation. You can select the channel you want to listen to. If you join us on YouTube, you can choose to join us on the Chinese channel or English channel. Our conference will start very shortly.
各位贵宾、各位长官、各位线上的先进
Ladies
平安。
and gentlemen, distinguished guests, good morning. The online international conference is called to order. We are hosting the impact and the response of the medical professional education in the post-pandemic era. We are celebrating our 125th anniversary of Changhua Christian Hospital. We are very honored to host this conference with Kaohsiung Medical University, Zhongguan Memorial Hospital, and also the PUNA, and also Walailak University, Thailand. We are also very honored to have the help of the Ministry of the Health and Welfare, and also Taiwan's Islamic Cultural Office in Thailand, and the Changhua County government. We are very honored to have speakers from Taiwan, Japan, the UK, the United States, Singapore, and Thailand to join us to share with us their experiences. I believe you will find the conference a rewarding experience. To begin our conference, I would like to have Superintendent Mu-Kuan Chen to say a few words to us.
Distinguished guests, speakers, moderators, ladies and gentlemen, welcome to join the 125th anniversary of Changhua Christian Hospital International Online Conference on the impact and the response of the medical professional education in the post-pandemic era. Changhua Christian Hospital was founded by Dr. David Lansbury III from UK in 1896. After more than 100 years of evolution and growth, Changhua Christian Hospital has become the most historical medical center in central Taiwan. Uphold the spirits of Christ Jesus' selfless dedication and humble service. Changhua Christian Hospital continually strives for innovative medical research and outstanding medical quality and provides comprehensive care to our patients. Since year 2020, the COVID-19 pandemic has greatly impacted healthcare, education, working conditions, and so on. Nowadays, it is crucial to continuously upbuild the medical professionals' core competency skills through clinical training backed up by scientific evidence-based approaches. This is the best practice to fulfill current global development and the social needs. In order to respond to the pandemic, a crucial goal is to encourage medical professionals to apply creative innovations and the latest technologies to transform the traditional medical service to best combat COVID-19. November 29th is the 125th anniversary of Changhua Christian Hospital. Changhua Christian Hospital is honored to host this conference to celebrate its 125th anniversary. We invite experts from well-known universities, research institutions, and hospitals from Taiwan, Japan, Thailand, Singapore, and the United States and the UK to share their experience in strategies and practice in medical education. We hope to guide medical educators in different countries to open up new directions for future development and foster exchanges between scholars. Lastly, I would like to express my sincere gratitude and appreciation to all honorary speakers, distinguished guests, and participants. I hope you enjoy and may God bless you all.
谢谢院长的勉励。接下来欢迎外交部驻泰国台北经济文化办事处徐卫明副代表。
Next, we are going to have the Deputy Representative Xu Wei-Ming to say a few words to us.
CEO Dr. Nina Kao, Director Sirima from Thailand, all participants from Taiwan and Thailand, ladies and gentlemen, good morning. On behalf of the Taipei Economic and Cultural Office in Thailand, as co-organizer, it's my great pleasure to welcome all of you to join the conference today. Firstly, I would like to congratulate on the 125th anniversary of Taiwan's Changhua Christian Hospital. Since its establishment a century ago, the hospital has been working with public sectors and medical centers to provide medical service to those in need. For example, they have dispatched several overseas medical missions. In addition, partner with Taiwan's government's new southbound policy, the Changhua Christian Hospital is designated as a pivot center to promote the medicine and health cooperation between Taiwan and Thailand. Since the COVID outbreak last year, the hospital has been working with the Taiwanese health sector to further the exchange and collaboration, to share practice and expertise, and to enhance resilience on healthcare systems. Taiwan and Thailand have been recognized for their capability and proactive response in curbing COVID. The work undertaken by all medical personnel have contributed to ensuring the system functioning all the time. However, the COVID pandemic has indeed posed threats and challenges to systems worldwide, not only on health service, but also on the education as well. It has been widely discussed about the repercussion of pandemic on medical education, and there are advocates that such impact should be managed on the basis of early response, alternative education options, and further actions such as transforming the traditional education and training format. Therefore, it is even more significant for all the representatives from Thailand and Taiwan together here today to address the impact on medical education and system in the post-COVID era. I would also like to take this opportunity to thank all the frontline medical personnel for their persistent devotion to saving lives in Taiwan and Thailand. As a bridging role, our office, the Taipei Economic and Cultural Office in Thailand, will continue to assist a closer partnership with Thailand. And I would like to also wish today's conference a fruitful and a successful one. Thank you. Thank you very much.
谢谢徐副代表。
Thank you very much, Deputy Representative Xi. Next, we are going to welcome co-organizer, Walailak University, President Dr. Sombat to say a few words to us.
Chen, a Superintendent of Changhua Christian Hospital, CCH. Dr. Wei-Ming, Deputy Representative of Taipei Economic and Cultural Office in Thailand. Mrs. Sirima Leelawongs, Director of Nursing Division, Office of the Permanent Secretary of Ministry of Public Health, Thailand. Ladies and gentlemen, I'm Sombat Thamrongthanyawong, President of Walailak University, Thailand. My first trip to the prestigious Changhua Christian Hospital in central Taiwan 3 years ago, in December of 2019, marked our beginning of coming together. Since then, in spite of this long-drawn out threat of the COVID-19 pandemic, Changhua Christian Hospital and Walailak University can still keep our invaluable partnership together through our successful annual international virtual conferences. Today, we still stand side by side to hold the 2021 International Online Conference on the impact and response of medical professional education in the post-pandemic era. As President of Walailak University, a fast-growing young university in the upper part of the south of Thailand, I can promise that we will keep working together toward our mutual victory in cultivating best healthcare provider in Asia and in the world. Rest assured that our partnership started 3 years ago is progressing now through our strengthened collaboration toward successful healthcare services for the benefits of all human beings. Ladies and gentlemen, history has proved that we human beings never give in to any problem, big or small. Today, we have advanced astounding application of artificial intelligence in healthcare that will ultimately optimize hyper-convenient care without compromising costs. We also about to witness the marvel of biotechnology in genetic engineering and in cell and tissue culture technologies. Throughout history, human beings are capable of battling several waves of deadly pandemic, like Black Death that caused over 200 million deaths, or Spanish flu that led to over 100 million deaths. I do believe that even though we are being twisted, spun, and knocked out by this menacing COVID-19, today's international collaboration will help us come out cleaner, brighter, and better with advanced medical profits. On this international collaboration occasion, may I also convey my warmest congratulations to Changhua Christian Hospital on the auspicious celebration of the institution's 125th anniversary on the November 29, 2021. This longevity of CCH's existence is a testament to its great achievement, and we wish CCH even greater success in the future. Again, thank you very much for inviting me and Walailak University participate in this consequential medical event. I wish the conference success and wish conference participants all the best.
谢谢Walailak
Thank you very much, President Sombat, for those kind words. Last but not least, we would like to welcome Madam Sirima, Director of Nursing Division, Ministry of Public Health, Thailand.
Honorable Superintendent of Changhua Christian Hospital, ladies and gentlemen, it is a great pleasure to congratulate you on the 125th CCH anniversary and appreciate you and your team to organize such a wonderful international conference on the impact and response of the medical professional education in the post-pandemic era. The conference has been addressed various issues around the impact and response of medical education in the post-COVID-19 pandemic, and what is to learn from past and recent experience in order to invent possible alternative transformation of the medical profession in the future. I firmly believe that each event will provide a great opportunity to exchange ideas and to share knowledge that lead to a new paradigm from the development of medical education and other related issues. Please accept my warmest greeting and gratitude from the attendance and contribution. Thank you.
好，谢谢泰国护理局的局长 Sirima 女士
Thank
的。
you, Madam Sirima's presentation. Next, we are going to enter our topic. The first subject is medical education in the post-pandemic era. The moderator is Dr. Yang Hong, co-education director of CCH. Also, he is a vice superintendent of Kaohsiung Medical University Changhua Memorial Hospital. He has a clinical physician's medicine's Ph.D. and also with a medical degree. Let's pass the ballot to the moderator, Professor Yang.
Good morning, ladies and gentlemen. Thanks to join today's international conference. It's my honor to introduce our first speaker, Dr. Eric Humble. Dr. Eric Humble is the Chief Research and Evaluation Office of Milestone Development of the ACGME of the United States. Eric is also Professor Adjunct of Medicine at Yale University, the Uniform Service University of Health Science, and the Northwestern University Feinberg School of Medicine. Eric is the winner of the 2016 John P. Harvard Award winner. The award is given to individuals who have made outstanding contributions to pursuit of excellence in the field of evaluation in medicine by the National Board of Medical Examiners of the United States. Eric is our good friend of Taiwan. He is internationally recognized of the consistent quality and significance of his decades of scholarship, learning, teaching, leadership, and the service as they relate to the assessment of clinical competence and the development and evaluation of expertise in medicine. Eric has devoted to his entire career to the scientific advancement of residence education and standards for accreditation, methods of evaluation for board certification, and perhaps most importantly, in the reliable assessment of clinical competence. Today, he will share medical education in the post-pandemic era. Let's welcome Dr. Eric Humble.
Hi, I'm Eric Humble from the ACGME, and it's a pleasure to be with you today for the CCH conference. What I'd like to cover with you in the next 40 minutes is what medical education might look like in the post-pandemic era. First, these are my disclosures. I am currently employed by the Accreditation Council for Graduate Medical Education, and I receive royalties from Elsevier Publishing for a textbook on assessment. Here is the outline for my talk. First, I'm going to talk about the impact of the COVID-19 pandemic on U.S. medical education as kind of an example of what's happening across the globe. Then I'll talk about organizational responses in the United States to these pandemic disruptions and the initial lessons that were learned. Then I will transition to talking about how we need to accelerate the move to outcomes-based medical education and how competency milestones and EPAs can support the implementation of an outcomes-based medical education approach. Let me start first with the early impact of the COVID-19 pandemic in the United States. As of August 26th, the date of this recording, there were over 38 million confirmed cases in the United States, and we have experienced now 4 peaks or surges over the last 18 months. And the second worst surge is actually occurring now. There have been over 630 confirmed deaths, with estimates being that it may be over 900,000 Americans who have lost their lives to COVID. The U.S. has struggled to effectively implement key non-pharmacological interventions, such as mask and physical distancing, over the last 18 months. And finally, we know that there's been substantial disruption throughout the 2020-21 academic year. This map just gives you a bit of a clue of the severity of the pandemic here. To the far right is the current peak that is occurring in August of 2021. But overall, these surges have been very disruptive, not only to healthcare in the United States, but also to graduate and undergraduate medical education. This slide highlights the impact of the pandemic on healthcare workers worldwide. In a March 2021 report from Amnesty International, they confirmed at least 17,000 healthcare worker deaths in 70 countries. However, in his address in May of 2021, the Director General of the World Health Organization estimates that 115,000 healthcare workers have probably died worldwide. With regards to COVID's impact on our graduate medical education system in the United States, where I spend most of my time, we, very early in the pandemic, had to give some relief to accreditation requirements, and hundreds of institutions were granted what was called either pandemic or emergency accreditation status. At the beginning of the pandemic, most of those institutions were in the Northeast and the state of Washington. Last summer in 2020, pandemic status was granted to many institutions in the South of the United States and the states of Texas and Southern California. Unfortunately, we're now experiencing a similar pattern occurring in the South United States in August of 2021. In this past winter, the majority of the country, between December and January, many institutions had to go on pandemic or emergency status. While we did give relief to some accreditation requirements, we did not relax duty standard because, again, it's so important that we not have fatigued learners in the workspace. As you might expect, the specialties of internal medicine, emergency medicine, critical care, and anesthesia were the most affected on the front lines of COVID-19 care. However, there was suspension of a substantial amount of elective procedures that are important to training, as you might imagine, in the procedural and other disciplines. So to summarize the early impact of the COVID pandemic in the United States, we found that the majority of training programs experienced periods of disruption that lasted 30 days or more, regardless of their location in the country. Over 7,000 programs reported 60 or more days of disruption, and the nature of those disruptions varied. In the domains of clinical care, there could be increases, as I noted, in intensive care, emergency departments because of the pandemic, or decreases in things such as procedures, or even having to delay care for cancer patients. And obviously, educational activities were also significantly disrupted. For example, our typical didactics or lectures had to be moved online or handled in different ways. There were also health impacts that occurred in our programs, and this is data from the early phases of the pandemic when we were able to collect such data. You'll notice that the majority of programs had to quarantine at least one resident or faculty member because of exposure or contracting COVID-19. And you'll also notice that a fair number had to be either hospitalized. And sadly, we also had a fair number of deaths occur because of the COVID-19 pandemic. Recognizing the impact of these disruptions on graduate medical education, the ACGME and the American Board of Medical Specialties drafted a set of principles in September of 2020 to guide this past academic year. Those principles emphasize the importance of informed judgment by program directors and clinical competency committees, and recommended a core set of assessment methods by competency that really should be completed by all trainees to make sure that for those graduating, they were truly prepared to enter unsupervised practice. We also created a multi-organizational work group that created a transition toolkit to support the medical school to residency or the undergraduate to graduate medical education transition. And this toolkit targeted medical school education deans, residency program directors, and graduating students. This is an example of some of the joint guidance principles that were released by the ABMS and the ACGME. First, resident and fellow assessment must address all 6 core competencies and the pertinent sub-competencies within that specialty. Second, the curriculum should be mapped to the competencies by using the sub-competency milestones. Third, the programs of assessment must be mapped to the competencies by using the sub-competency milestones to ensure all core competencies are assessed. And you can link to this guidance principle document by clicking the ACGME link on the slide if you desire. This is an example of the assessment methods that were recommended for each of the 6 general competencies. And again, we wanted to make sure that all 6 of these were adequately assessed even during the pandemic. The 4th principle was that review committees, those are the committees at ACGME that are tasked with judging the quality of the program, will really continue to focus on that quality of the educational program being delivered. And finally, we recommended before last December that each residency and fellowship program's clinical competency committee should review the current status and progress of residents and fellows scheduled to graduate in June of 2021. And there's actually a program requirement for that. We wanted to make sure that if there were folks who would be graduating in June of 2021 that could potentially have deficiencies, that they were identified during this past year. So there's an opportunity to help them correct those deficiencies prior to graduation this past June. This is the cover of the transition toolkit that I mentioned. This was published and then placed online in March of 2021. Again, this is also available to you and you can find it on our website. There are a number of different components of this toolkit, but I'll focus for a moment on the assessment piece. And here you can see that we gave guidance during these various periods of the transition to medical schools and residency programs to help them in this transition. I'll just give you one example. We recommended that between March and June of 2021, that medical schools should consider conducting an initial assessment using the specialty milestones and help the student use this as almost kind of like a needs assessment in preparation for entering their specialty residency. Then in June, once the graduating medical student became an intern and entered the training program, that the learner should again be introduced to the specialty milestones, that they should conduct their own guided self-assessment with the residency program director, and that they should use the milestone guidebook for residents and fellows that we have available on our website. And then finally, between July and what we're hoping is currently happening, that they front load direct observation of core clinical skills with these entering interns to make sure that they're progressing in the way that they would hope. And if they have areas where, again, they may need a little additional help, it's better to get that early than to discover it later on in the year. So for us, we've done a lot of reflection as a result of the last 18 months, and there will be a lot more reflection to come. But so far, this is what the pandemic has exposed for medical education in the United States. The first is reliance on time and training as a proxy for competence became untenable. For example, if you depended on making sure your resident had a couple months on various hospital wards or specialty services, that became terribly disruptive. And in many cases, just simply didn't occur. So you couldn't depend on just simply having 4 weeks, for example, of an oncology rotation to depend that they would learn oncology. Second, that the usual proxies for assessment were also significantly altered and disrupted. we tend, again, to use the proxies of volume of procedures or clinical experience or the distribution of that experience, such as the types of procedures you do, to really judge whether or not somebody's ready without really looking at how well they can actually do those procedures. Just simply counting numbers has really been a traditional metric, and yet we know that it's insufficient. And the pandemic only further emphasized that. As I mentioned earlier, depending on rotations to ensure clinical experiences that then provided opportunities for assessment were terribly disrupted in many places. And then a number of our high-stakes examinations, including our licensing exams, were terribly disruptive, and one was completely suspended and has since been eliminated. That would be the Clinical Skills Step 2 exam that has been traditionally administered by the National Board of Medical Examiners. That is now leading to a new reflection on how to evaluate clinical skills moving forward, since that exam will no longer be available. Third, it highlights substantial gaps around transitions, such as the one I just mentioned, moving from medical school or undergraduate training into graduate medical education, postgraduate residency fellowship, depending on where you work in the world. And then finally, it further exposed specific gaps in assessment, such as our ability to assess patient-centeredness, our ability to assess the skills and quality improvement in patient safety, and also to assess interprofessional teamwork and communication, things that we are already struggling with, and that struggle was only further exacerbated by the pandemic. So the universal conclusion that I've heard from many folks, and we have certainly reflected on, is that managing educational programs and determining competence of learners during this pandemic would have been a lot easier were the medical education system in the United States further along in implementing outcomes-based medical education. So how do we do that? How can we accelerate the implementation of an outcomes-based medical education approach, building on the lessons and disruptions from the pandemic? Let's first start with some definitions. This is a really nice article from Ron Harden, who's been a leader in outcomes-based medical education. This was a nice kind of summary article from 2009. The central tenet with an outcomes-based approach is you start with the end in mind. In other words, focus on what type of physician will be produced, and the structure and process of the programs and assessments should flow from those outcomes. As Ron notes, and others have as well, that educational outcomes should be clearly and unambiguously specified. In other words, we have to have a clear mental model of what it is the graduating trainee can do at whatever stage of career they're moving into. And that these educational outcomes should determine the curricular content, organization, and timetable, the teaching methods and strategies, the assessment processes that will be used, and what the learning environment has to be able to provide in order to support this professional development. You'll notice all these are important. It's not just about assessment, but that curriculum and how that curriculum is delivered is very important. And as I noted earlier, we've seen a lot of disruption around that. Let's start with the definition now and kind of shift from just looking at outcomes and how do we operationalize an outcomes-based approach. This is where competency-based medical education comes into play. And this is a definition from an international group of educators led by the Royal College of Physicians and Surgeons of Canada. They define CBME as an approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from analysis of societal and patient needs. In other words, the ultimate outcomes are the quality and safety of care we deliver to our patients and our communities. CBME de-emphasizes time-based training and promises greater accountability, flexibility, and learner-centeredness. It doesn't mean that time isn't important, but the principle here is that time should be seen as the resource and not an intervention. Again, as I showed, using time as a proxy for competence became very problematic during the pandemic. So, as I said, the ultimate goal of medical education is to meet societal and patient needs. And we can represent that through a framework called the quadruple aim, where we strive for better outcomes at lower cost and improve patient experience, while also making sure that the clinicians themselves have an improved experience and that we attend to their wellness, their safety, and making sure that they're not fatigued. With regard to patient experience, we ground those in what are called the 6 aims of quality. Care that should be effective, safe, efficient, timely, equitable, and patient-centered. So if this is the ultimate goal, our job is to design educational programs that integrate curriculum and assessment to ultimately provide the ability for our graduates to strive for this quadruple aim. And you'll notice that in this diagram, the competencies help define the curriculum, and the educational outcomes are defined typically by things called milestones or EPAs, which I'll mention more in a little bit. But you also notice that this is an ongoing loop. I'm sure you've heard the adage that assessment drives learning, but learning, or the curriculum, has to drive the right kind of assessment. And ultimately, this has to occur in the context of a high-functioning clinical learning environment. That if you work in a toxic environment or in an institution that isn't providing high-quality care, it's very hard to achieve both the clinical and educational outcomes we're all seeking for our graduates. And to that end, it's also important to recognize that in medical education, there are a series of interdependent nested relationships. As shown on this diagram, learners are nested within a training program, whether it be medical school, residency, and so forth, that are nested within institutions, that are all nested within a local community, and that are affected by federal and state government type laws and policies. These are interdependent relationships, and they can affect both education and clinical outcomes. And it's important we not lose sight of that, again, as we design and transform our programs moving forward. I want to shift now as a way to think about competency-based medical education that I hope will be helpful to you. And this is known as the core components of CBME, something that was led by Elaine Van Mel from Queen's University and the Royal College in Canada. These are the 5 core components. You need an outcomes-based competency framework. You need progressive sequencing of the competencies. You need learning experiences that are tailored to those competencies, and therefore teaching that is also tailored to the competencies. And finally, the 5th component is that you need programmatic assessment. Let's explore these a little bit. I'm going to point out one thing from this slide. We can see that across the top row there, we've listed the 5 components. But down below, in Elaine Van Mel's wonderful paper, she's pointed out that each of these are deeply informed by important educational theories that they themselves have undergone empiric research to support. And while CBME is growing and we're beginning to understand successful CBME programs, it's important to recognize that CBME is a deeply evidence-informed approach. And as we build more empiric evidence for the actual combination of these things in the CBME program, it's important to understand that these are all undergirded by important theories in research in their own right. So I'm going to briefly review these 5 components. I'm going to start with the competency frameworks as just a brief review. Then I'm going to talk about these middle 3 because I think they're really important and in some respects maybe the hardest piece of the CBME components. That is sequential progression and tailored learning experiences and competency-focused instruction. Because in order to really achieve these 3 columns, you have to think developmentally. And then we'll end with a comment about programmatic assessment. A quick note or review on the general competencies. A general competency framework is really important. This is the 6 general competencies from the United States. I know a number of you have actually seen this. And when I'm teaching this to my colleagues in the state, I make a couple points. Love them or hate them, competencies have required graduate medical education to focus on important abilities long neglected in healthcare. And I mentioned some of these earlier, such as interpersonal skills or interprofessional teamwork, quality and safety. These things were called out over 20 years ago because they're important to care. And the question I would ask you, if not competencies to specify the educational outcomes or serve as our mental model for them, then what would you replace it with? And at some point, I think that's going to happen. That's just the nature of the way science works. But right now, these really help guide us in making sure we're attending to those things that are important, that are connected to both educational outcomes as well as clinical outcomes. And so remember, the competency frameworks are nothing more than that. They're an organizational framework to guide curriculum and assessment. Think of them as kind of scaffolding, and that these frameworks help us build shared mental models among our learners, our faculty, and those who are providing the training. Another really important point about competency frameworks is that they do not represent the totality of a discipline or of all professional development. They're called core competencies for a reason. There are other things that are important. And this is where we need the wisdom and experience of our faculty to fill in the space, if you will, around these competency frameworks. And in the end, what competencies do is help us to define the educational outcome or abilities of individuals. As I often say, if you hear competency that ends in a Y, think ability. That's really what we're focused on, is the individual. And these represent the educational outcomes of that individual. Let's now move to those middle three columns. How do we support sequential progression, tailoring of learning, and tailoring of teaching? And I'm going to cover a few key concepts in learner development. Not all of it, but give you at least a taste of some of these important theories and the research around them that we need to incorporate more into our medical education programs. The first is the concept of a learning curve. This is one of my favorite papers from Martin Pusick. I strongly recommend it to you, where he points out that all of us experience this phenomenon or this learning curve, and it's not a nice linear line. In other words, it's not a nice 45-degree incline. It is sigmoidal. And our learners are going to spend most of their time when they're with us, particularly in medical school and in postgraduate training, on the steep part of that curve. And so as we think about that intensely developmental period, how do we support that? Here's an example of why it's so important, about why we have to do some tailoring. This is also from the same article, where Martin had 18 pediatric residents complete a series of readings of ankle radiographs. And they were asked to look for abnormalities, lesions, or whether or not the film was normal. And if you look on the left, the group mean, you'll see there's this initial steep learning curve where people are getting better, and it's really a challenge. But as they begin to get to about 100 radiographs, the curve begins to flatten out a bit, and the slope becomes a little less acute. And this is pretty typical for a learning curve. But if you shift your focus to the right, those are the individual patterns of the 18 residents. And you'll quickly notice they're all pretty different. Now, yes, there's some that kind of group together, but you also notice there's some that get pretty good at this quickly, and then they plateau. They don't really reach expertise or mastery, but they'll get to about 80% accuracy. And then there are others that even after reading 200 films are still only about 2/3 accurate. So that's going to require some tailoring, and think about the sequencing in order to help these individuals actually achieve the outcome. Because if we define mastery, for example, being able to be accurate over 80 or 85% of the time, none of these 18 actually would reach that standard. And yet that would be the goal. Another really important body of work is known as the Dreyfus Stage Model Development. This was created back in the 70s by Hubert and Stuart Dreyfus. This is an example providing the slide about what the various stages of development would look like for clinical reasoning. And so they define these 5 stages: novice, advanced beginner, competent, proficient, and expert, as a way to think about professional development. Understanding, again, it's not a stepwise linear process, that each of these stages will have their own challenges, they'll come at various speeds, but at least it gives us a mental model about what development actually looks like. And this is something that has been very helpful in informing the milestones. Another really important body of work is known as deliberate practice. This comes from the field in studying how people become experts. One of the leaders in that field was Anders Ericsson, who I'm very sad to report died suddenly in the spring of 2020. We miss him greatly. But back in the mid-90s, he defined deliberate practice as individualized training activities, especially designed by a coach or teacher, to improve specific aspect of an individual's performance through repetition and successive refinement. Think about what I just showed you from Martin Pusick's article. What, instead of just simply having folks read films and getting some quick feedback, what if it was more deliberate? Could we help those folks reach mastery more quickly? And as Anders points out with his colleagues, to receive maximal benefit from feedback, individuals have to monitor their training with full concentration, which is effortful and limits the duration of daily training. So in order to really strive for expertise, you have to intensely focus on what you're doing. And that could be a real challenge in the chaotic clinical spaces of our healthcare systems. If you want to read a really accessible book on deliberate practice, I strongly recommend the 2016 book by Anders Ericsson and Robert Poole. It really nicely describes decades of research in deliberate practice and how people reach expertise. But I want to pull a couple key points out of that book for you. One is that it requires a field that is reasonably well developed. And the reason for that is that there had to be clear mental representation of the task of that field are essential. Anders, for example, studied early on things like music and chess players and other things, and there's pretty clear sense of what excellence sounds like, for example, in music or playing a violin. As Anders began to work with folks in medicine, he was a bit struck that the mental models weren't as robust, that there's more variability, and they weren't always necessarily shared. And this is really important because in order to engage and deliver practice, you need to have a teacher who can provide practice activities based on that shared mental model of excellence in order to help learners improve their performance. And I would argue in medicine, we're struggling in some areas of shared mental models. The final theory I'll just briefly mention, again, strongly recommend the whole body of work from Bill McGahey and his colleagues, is mastery-based learning. The principles here I think are really critical. With mastery-based learning, excellence is expected and achievable by all learners who are able, motivated, and work hard. There is little to no variation in measured outcomes. Learning in any domain depends on learning a sequence of less complex components. There it is again, right? Progressive sequence, right? Thinking through the lens of a learning curve. Because ultimately, if learners receive the optimal quality of instruction, in other words, curriculum, and learning time required, the majority of learners should attain mastery. We're not shooting for the floor. We are always striving for excellence, or in the words of Bill McGahey, mastery. That should be the outcome. Let me now move to that final column, programmatic assessment, and make a brief comment here. We need to look at programmatic assessment through the lens of a system. This is just a rough schematic of what a system looks like in the United States. Remember, the ultimate goal is to meet public and societal needs. And so what does that mean for the training program? Well, from an assessment perspective, as we mentioned earlier, you have to have the right combination of assessments. And that's represented here in that gray rectangle. For this particular program, this might include direct observations of clinical performance, audit and performance data from the medical record to assess things like quality and safety, multi-source feedback to assess professionalism, interprofessional teamwork and other communication skills with patients and family, simulation for procedural skills, and an in-training examination to at least get a baseline assessment of somebody's knowledge capabilities. All of these assessments should generate longitudinal data, that's the D in the red oval there, that comes to a committee. In the United States, we call that the Clinical Competency Committee. And that committee undergoes a synthesis of all this data by reviewing the quality and nature of the data and then having a conversation to make a developmental judgment. We represent those developmental judgments on something called milestones. I'll show you in a moment. Those developmental judgments should then be fed back, those are the green arrows, to both the residents or fellows, but also back to faculty and program directors in the program to constantly help it get better. And this needs to be an ongoing iterative loop. The other thing I'd point out from the slide is that residents need to be active agents in this system. They need to contribute to their own assessments. They need to participate and engage in those assessments for their own professional development. Because remember, they're on this steep learning trajectory and they've got to be active agents with us and reaching those educational goals. At some point, you will make a graduation decision. And I would argue for the standpoint of the public, that's a high stakes decision. We have to make sure that the entrustment we make when we say somebody's ready for unsupervised practice is one that is grounded in good evidence and good judgment. So thinking it through the lens of the system and all of these interdependent components, there are some important, again, principles that should guide your program of assessment. The first is effective assessment practices require a programmatic approach and a deliberate and arranged set of longitudinal assessment activities. This isn't a one and done. You need to continually be collecting assessment data over time to make sure people are on the right trajectory. Second, a model programmatic assessment can optimize learning and certification. So what we mean by certification here is that when you got to make that final judgment that you can certify they're ready for unsupervised practice, that's a summative high stakes decision. A really good program of assessment can help you do that well. Third, that individual data points in the assessment program have to be maximally informative to the learning. We should not be collecting assessment data just for the sake of it, or only to make a high stakes decision. Anytime we do an assessment, it has to help the learner get better. And that should be true for whatever assessment we use. Fifth, these aggregated assessment data points can be used for higher stake pass-fail and remediation decisions. Again, if it's done well, accurately, and with validity. And it's important to note the higher the stakes in the assessment decision, the more data points you will need. This is a really important point. You can't just wing it on a couple assessment. You have to make sure you've got a program assessment with multiple data points collected over time to make these high-stake judgments. And finally, expert professional judgment assessment is actually imperative and requires new approaches to deal with biases. That's where group process, when it is managed well and led well, can really make a big difference in assessment and making these type of decisions. Over time, we'll clearly be able to use more in the world of machine learning, et cetera. But I do not foresee a day anytime soon where we will not need the wisdom and expertise of folks involved in the assessment program to make those expert-informed judgments about our learners. And I would argue that those expert-informed judgments are actually incredibly valuable as part of coaching and feedback. I've been alluding to this before, but I do want to reemphasize that there are a minimal combination of assessment methods and tools that have to be part of any program of assessment. I would argue that, at least for us in the United States, this is what they are. You have to have faculty summary evaluations of some type, whether it be after a week, after a rotation, whatever, but we need their kind of collective judgment. And if it's done well, you can actually assess multiple competencies. Direct observation is absolutely critical, and we still don't do enough of it. It is important for so many of the competencies: patient care, clinical skills, interpersonal clinical communication skills, medical knowledge, particularly assessing clinical reasoning in vivo, in other words, in the clinical practice space. Multi-source feedback is also essential, as I mentioned earlier, for professionalism, interpersonal communication skills, and systems-based practice. And then we don't use enough of audit and performance data, in other words, pulling data out of clinical charts, including, by the way, patient experience. What did they experience through surveys? This is essential for us to assess practice-based learning and improvement and systems-based practice. And then increasingly simulation, particularly for procedures, I think is going to become a must. I think it's getting harder to justify we can just do this at the bedside, but that for most of our learners, they should start in the simulation lab before they touch a patient. And Bill McGahee's work is extremely compelling in this space. And I, again, encourage you to read it. And then if you have access to an in-training multiple choice exam, use it. It's a good, as I said, method to kind of assess capability or capacity in medical knowledge that does not replace the assessment of medical knowledge when caring for real patients, however. So we've now kind of gone through those 5 components, and we need to move a number of them forward more aggressively if we're really going to achieve the goals of outcomes-based medical education. But the question then becomes, how do we operationalize competency-based medical education? Well, as I alluded to earlier, competency milestones and/or entrustable professional activities can be helpful here. I'm just going to briefly review those for you. This is an example of a milestone from the United States. We use this as shorthand, but what a milestone really refers to is that within each of our general competency is a subcompetency. In this case, for patient care, is care of the acutely ill patient. And the milestones are narrative descriptors across 5 levels of skill. Okay, so you see level 1 through level 5. So the milestones themselves are actually just the narrative descriptors. And for our new milestones, particularly the 2.0 versions, we have limited to 3 threads, and they have to be developmental in thinking. Now, one of the things that we really want our faculty and our clinical competency committees to do as they're assessing where they think a learner is developmentally and using this rubric is to focus on the narrative, not the number. The number is nothing more than a code. It's helpful, and I'll show you in a minute that we can use it to track folks and get a sense of what learning trajectories are. But if that number is not attached to an accurate reflection of where the learner is developmentally, then the code isn't itself very useful. And so this is something we really emphasize. And increasingly, we're arguing that you really need to start with the narrative. And there is work that has shown that if you start by matching a learner to a narrative instead of a number, you actually can be more discriminating and more accurate. And the other thing I'll just point out in the United States, that for us, our recommended graduation target in all of these subcompetencies is level 4. And level 4 roughly equates to proficiency in the stage model of development type framework. And so if you read down that column, That's what we'd expect someone to be able to do at the time of graduation. And that specialty believes, in this case, it's family medicine, that prepares them to be successful to enter unsupervised practice. And so we use these competency milestones or narratives to help integrate curriculum and assessment. Remember that bidirectional loop I showed you earlier across the learning time when they're in the program. And residency, as I mentioned, is on the steep part of this curve. When they come out of medical school, they're mostly going to be an advanced beginner within the specialty they're entering. They might be competent in a few things, but in most things, they're going to be an advanced beginner. And so they're going to spend the next 3 to 7 years on our specialty programs, moving up the steep part of the curve with the goal to reach proficiency. And again, for us, that's level 4 in the milestones. So I mentioned earlier, if those codes are an accurate reflection of where they are developmentally, we can do some really interesting work. This is an example from some of our early work. This is from emergency medicine, where we can map every single trajectory nationally for the 1,336 residents that graduated in June of 2016. Emergency medicine was one of the very first specialty to use milestones. And you'll notice that we can then sort out those who reached level 4 at the time of graduation and those that did not. And those are depicted here in yellow. And the purpose here is that can we find signals earlier in their training where it might be a signal they're not going to reach level 4, and it allows us to identify them earlier for the purposes of helping them to implement an educational intervention so that they can ensure or at least enhance the probability they're going to reach level 4 by the time of graduation. And so we now have these things called predictive probability values that for this particular group of residents in June of 2015, they were 1 year from graduating, right? And they're at level 2 on the milestones with just a year ago. What is the risk they're not going to reach level 4? And how can we then identify them? So at least we have a year to intervene. And the earlier we can identify, the better. And that's the type of work we're doing. But this just shows you the power of these developmental models, or at least the potential power if we use these rubrics or these frameworks well. Another really important concept related to competency milestones is entrustable professional activities. And this is the genius of Ola Tenkot and his colleagues. This is work that has been happening around the same time as the competency frameworks. And Ola defines EPAs as the routine professional life activities of physicians based on their specialty and subspecialty. And to me, one of the most important aspects of this wonderful construct is the concept of entrustable, which means a practitioner has demonstrated the necessary knowledge, skills, and attitudes, or I'd argue competencies, to be trusted to perform this activity unsupervised. So the concept of entrustability, I think, is really important. And we use trust a lot in medicine. For example, if we have residents who are on call overnight and we're not in the hospital, we've made an entrustment that they'll be able to handle what they're asked to care for that night. And if they get into a situation where they can't, that they have good judgment to call us and ask us for our help. That's a concept of entrustability or entrustment. Now, there's a lot of overlap between competencies and EPAs, but I just want to make a few distinctions that I hope are helpful. Competencies define the core abilities of the individual. Remember, they define the educational outcomes, what the individual can do. Milestones just simply describe competencies and developmental narratives. That's all. You can create milestones for all kinds of things, but for us, we've used that concept of milestone to define these competencies and developmental narratives. Whereas EPAs define the core activities health professionals perform in daily practice. Competencies are needed by the individual in order to effectively perform the professional activity. And you can see from this slide, we can put the two concepts together. EPAs depend on good construction using the right competencies. And in this example, it's provide telephone advice and management of patients. You'll notice that there are 3 that are really called out here for assessment purposes. It's medical knowledge, interpersonal communication skills, and practice-based learning and improvement. Now, we know that across those 5 levels, we have narrative descriptors. So what we can do if we're looking for what somebody should be able to do or look like at the time of graduation, where they're at the oversight only stage, we can take all those narratives from each of those subcompetencies and create a story. And level 4 is the graduation target. You can see in this slide actually that these models align very well. It's interesting to me that most of these frameworks are 5 levels, give or take 1 or 2. But the milestone levels line up very well with the various levels of supervision that have been promoted by Ola and his colleagues in using EPAs, where early on you just basically observe at milestone level 1, where by level 4, you're just getting distance oversight and you're pretty much ready for full unsupervised practice. And so this allows us to use, for example, entrustment scales with faculty that then very nicely translate into milestone ratings, for example. We see a lot of folks doing that in the state. And so to kind of bring this to an end, accelerating outcomes-based medical education will require better integration of curriculum and assessment, transitioning away from over-reliance on time and volume-based proxies, embracing all core components of CBME, greater engagement from learners as active agents, rethinking educational design such as rotations. Do we rely on them too much? We'll need to evolve effective practices for competency milestones and EPAs, still much to learn. And we have to embrace implementation science as we make these changes to guide our transformation. So in conclusion, the pandemic further exposed major limitations in our current medical education models. The need to advance implementation of CBME has become more urgent in our view. Moving to criterion reference, developmentally focused curriculum assessments is challenging, as I've noted, but it's really important. And that competency milestones and EPAs can help in implementing competency-based medical education and developmental assessment. And that faculty development, helping our faculty make this transition, will continue to be essential. So thank you very much for having me. I look forward to taking some questions. Please feel free to reach out to me at this email address. I'd be happy to send you additional materials if you heard anything today that would be helpful. Take care and please stay safe.
Okay. Many thanks to Professor Eric Humboldt and my girlfriend. So nice to see you again in the online.
Yeah, likewise. I really wish I was there with you.
Thank you for your comprehensive and inspiring talk. And now it's open to the audience, the question and response. And maybe I can ask the first questions. So you mentioned the very important point, the competence-based medical education. Usually maybe think that the final outcome may be competence-based. But you point out very important that mastery-based. So every learner should become or expected to become a master. So, but you, from the program assessment, from the point of view, you know the very wide variation of the faculty. So in your experience, that's how to deal with this problem, because that is, I think it's very important, particularly in the Clinical Competence Committee. So CCC is the central of the program evaluation. So, and please, and what's your comment? Thank you.
Yeah, no, thanks for the question, Dr. Yang. I think there's a lot actually in there. One issue I think is really important is to see faculty development as an essential aspect of actually not only improving education, but also improving clinical care. We need to think as faculty development is not as a nice to have, but just part of professional development. In our other work, we've certainly seen that, for example, in our direct observation research, faculty use themselves as their primary frame of reference. So what's really important is to make sure that faculty themselves have high levels of competence in what they're judging. So I think your point's really important. And the reality is, for us anyways, in some of these competencies, I can tell you that I trained in the early 90s. I was not specifically taught quality improvement, interprofessional teamwork, care coordination. And so I didn't get great training. And so I've had to learn that as a faculty member about what that looks like. So I would just make that as a really important point. Group process can help by using the collective wisdom and expertise of a group. But I think we all have to make a commitment to get better, because to your point, the ultimate outcome here is to improve the care and health of the populations we serve. So I'm totally with you on this. Big challenge.
Okay, thank you. So I think now, usually, like Professor Ron Harden mentioned that actually no faculty development, no curriculum reform. Actually, the faculty development. So I think faculty is the central role.
It's certainly very important.
Okay, the final question that you mentioned accelerating the outcome-based medical education. So do you have any experience that any program or any discipline in the United States have shortened the training duration?
There are now several examples where that has happened. Probably one of the best known experiments actually happened in Canada at the University of Toronto in the orthopedics program. That has been published. It's a medical teacher by folks like Peter Ferguson and others, and they were very successful in doing that. There is another program called Educating Pediatricians Across the Continuum that have been able to shorten the length of medical school and have people enter residency in pediatrics early. And this has been most successful at the University of Minnesota. We currently have a pilot going on in plastic surgery, looking at time variable progression within plastic surgery training. And then we have a group of programs that are using a concept called promotion in place. They may not be able to leave an institution, but the concept is that if you have an accelerated learner, you can promote them by letting them do other things, maybe begin their fellowship, reduce the level of supervision to keep them moving forward and not hold them back. And so I think we'll begin to see more of those types of programs in the United States. So stay tuned.
Okay, thank you very much. I think because the time is very constrained, so I have
totally
to close the
understand.
session. And thank you so much again. Thank you. Thank you.
Thank you for having me. Yeah, listen, have a great conference. Congratulations on your 125th anniversary. Thanks, everybody.
And I'll keep in touch with you. Thank you. Thank you very much.
Bye-bye.
Bye-bye.
好，谢谢杨教授。
Thank you, Professor Yang and Dr. Eric, sharing. Our next section's subject is to rethinking medical education. Is it time to get back to basics? We would like to invite Dr. Yang as a moderator again to introduce as a speaker.
Okay. So let's move to the second speaker. I would like to briefly introduce our second speaker, Dr. Samaraskara Dujiba. And Dujiba professor, he is now the current director of Center for Development of Teaching and Learning and senior director of Center for Medical Education in Yongluli Medical School of the National University of Singapore. And he is also the senior consultant at the Ministry of Health in Singapore. Dr. Dujiba graduated from the University of Colombo, Sri Lanka in 1995. And after training as a physician, he developed further in health professional education in the Netherlands. And he is also very outstanding and has been invited as the faculty of medical education in the United Kingdom, Singapore, Malaysia, and Edinburgh. Dujiba has been involved in curriculum development, quality assurance, and accreditation level health profession courses at NUS in Singapore. He has published widely in peer-reviewed medical education journals and authored book chapters relating to medical and health professional education. At the regional and the international level, Dujiba is the president of the Western Pacific Association of Medical Education, WPAME, and an executive board member of the World Federation of Medical Education, FMME, and he also chairs the Asian Pacific Medical Education Conference in NUS. And this conference is quite popular and very high standard, high quality in Asian countries. Dujiba is a member of the Aspire for Excellence panel at the AMI to evaluate medical schools that have achieved excellence in specific areas of faculty development, assessment, etc. And he also co-chairs the Asia Pacific Scholar Network, APME-Net. And actually, Dujiba is also our Taiwan's good friend. He visited Taiwan several times and also visited a visiting professor of Tzu Chi University. Dujiba is the editor-in-chief of the Asia Pacific Scholar Journal and serves on the editorial advisory board of the Annals of Academic Medicine Singapore and the AMI online journal, Med-ED published. Today, he will give us the topic, the Rethinking Medical Education, time to get back to basics. Let's welcome Dr. Dujiba.
Hello, I'm Dujiba Samarasekara from the Center for Medical Education at Yong Loo School of Medicine, National University of Singapore. Let me first upload my set of slides. The Center for Medical Education focuses on international collaboration like this, and also the scholarship of teaching and learning, where we focus on our education research, scholarship, especially the Asia Pacific Scholar and our Journal of Asia Pacific Scholar and the Asia Pacific Medical Education Conference, which some of you may have attended in the past years. Now, I want to start with the disclaimer that the ideas and views expressed here is entirely mine as my personal experience as a health professional educator. And the views expressed do not represent an institution or organization unless otherwise stated or referenced. So with that, let me go back to my topic, the Rethinking Medical Education, time to get back to basics. Now, the focus of this session is basically to reorient it and realign ourselves with the massive changes that has been happening over the past 2 years because of the pandemic. And also a lot of us looking at the future from a different lens as the new normal. My argument here would be that we have to take stock of things and we need to focus on our core mission and how best to do that. And for that, we need to actually strengthen our basic training. So therefore, the focus would be to reflect on how best to develop a safe, effective, efficient medical professional to practice in a dynamic and rapidly evolving practice environment. And of course, there will be more questions than answers for us to reflect. And my presentation is love towards all and malice towards none. So with that, let us look at some of the clinical practice, some of the challenges we are facing. We are facing not only the technical part, but also the environmental issues with the climate change, pollution, the scarcity of water and food. There's socio-political and also with regard to equality, equity issues in social, ethnic, racial, religious, and economic fronts. The practice-specific ones. For example, the professional practice, the legal, ethical, and also the management issues. The medical professionals are increasingly being asked to involve in challenging situations, and sometimes some of these issues are beyond their training. There's also changing environment and treatment protocols that has been there for the past several decades with new things that we are discovering. So quite a lot of new management and treatment protocols. And of course, the use of IT and automation in patient care. This is now again a big challenge. We have now embraced the use of IT, automation, artificial intelligence in medicine, quite rightfully so. And of course, the pandemic situation over the past 2 years has kind of forced almost all of us in whatever capacity that we are in clinical practice to move to this arena and also to incorporate these areas in our own training. So the focus is that how do we actually take stock of things to develop a competent, caring medical professional, right? With all these changes happening around the practice as well as the training environments. Now, I want to take a step back, and from medical education, I want to go into aviation update and then kind of, start reflecting. Well, this came out in New York Times just before the pandemic in 2019, that it highlighted a report by the Federal Aviation Authority. And what it said was that with increasing automation in the aviation industry, especially for pilots with modern technology in these planes, that the basic skills of flying of pilots, it's dropping drastically. So it actually shared that the pilots rely a lot on autopilot and they become systems operator rather than a stick and a rudder pilot. So in short, that the pilots are losing their skill of just flying a plane, but this and looking at all the automation. And this has severe consequences. The article goes on to highlight, as a result, they may not exactly know or recognize quickly enough what is happening to the aircraft. And by the time that they figure it out, it may be too late. And this was the case in the recent Lion Air crash in Indonesia, and subsequently the Ethiopian Air as well, killing all 189 people, the 737-400 fiasco, where the investigators think that the pilots struggled to control the Boeing aircraft after its automated system malfunctioned. And it was too late that when the pilots realized that it is actually the problem with the autopilot, and the plane crashed with all the people inside the plane dying, both in the Lion Air and the Ethiopian Airlines jet. Now, I think this is something that is really worrying in the airline industry. However, this was highlighted way back in 2013 in one of the FAA reports, where they highlighted the lack of basic piloting skills because of automation and use of all these modern technologies. So they also attributed 2013, one of the crashes of Asiana Airlines jet in San Francisco, where 3 people died. And unfortunately, most of them died because of the ground handling rather than the crash itself. They survived the crash, but the fire trucks ran over them. That was a very unfortunate thing. But then again, it was highlighted that it is in the FAA report itself that there's a serious issue with regard to the aviation industry. Now, this is worrisome. And let's now try to reflect our own medical training and medical education and the way we practice now. Increasingly, we are moving into an automated area. We're depending a lot more on automation, artificial intelligence, machines for diagnosis, even to read reports, pathology reports, or even the basic EKG reports are all read by machines rather than by students. So there's also an argument in medical education and clinical practice that we need to change and we need to leverage on that. There's no question or there's no argument about it. But I think what we really need to focus is that in the medical school, in the basic residency training, are we giving them the necessary training or skills? So let's now reflect on medical errors, right? So this is something I have actually taken from Ole Tenkat from his EPA International Workshop, which is it's a wonderful workshop, and highly recommend that workshop by Ole and his co-workers, where he highlighted the number of errors and the deaths from hospital errors. So you can see that annual deaths from medical error is around 44 to 98,000 in year 2000, and this is not a secret. This was known by many, especially this was way back in 2012. This was at NHS. They call it the killing fields. The report that was put out by the Director Health Services of the National Health Service. It showed that when the new doctors actually take over, the mortality spikes. Not the morbidity, but the mortality. The people who are not supposed to die in hospitals, they die because of medical error by the young doctors who have graduated from the medical school, who have gone through the residency program, whom we have assessed and trained. But yet, they're making those critical mistakes and the death rates are going up. It's not only UK, from Australia, from US, from Canada, it's the same thing, right? It has been reported. Now, the most interesting thing is with all these modern training and technologies and use of equipment, the protocols, the 2000 death rate should have gone down. But actually, if you look at the very recent report, right, by John Hopkins study, it has shown that actually it has increased tremendously by nearly 4 folds. Right, so about 250,000 people in US die from medical errors, and one report claimed the number to be as high as 440,000, close to about 500,000. So this is really worrisome, right? A major medical error leading to death, right? So why is this happening? With all our curricula being refined, we are training things, we are using all kinds of modern technology, yet our young doctors and the residents, they're making mistakes. Our practitioners, they're making mistakes and people are dying. Well, this is a very interesting piece of newspaper article I picked up some time ago. Michael Jackson was my favorite, my time. You can see my gray hair. But this is sad because I think his physician, Michael Jackson's physician, is a certified cardiologist. But during that moment, he panicked. Now, is it something to do with training, or is it something to do with his own characteristics or the way he attended? We don't know. But still, it is quite interesting piece of news. So, with the loss of basic clinical skills have been highlighted again, and this is no secret. More and more, our medical training programs are moving towards more automation, less time that are given for our students for the basic to be trained in basic clinical skills in identifying physical signs and symptoms and coming to a diagnosis, learning from the very basic training of diagnosing, coming out with a differential diagnosis. So we are packing the curricula with a lot more things, with analytics and various other things, quite rightfully so. But are we kind of losing the plot? Now, this is the thing that I want to refocus as a medical educator. Now, this is quite interesting. This was a 2011, our graduate exit questionnaire given to our students who have completed the entire medical program. And they very interestingly highlighted a fact, right? So this is a quote unquote. One of the students said that medical students in general seems to be considered liabilities for hospital staff and patients. This is because that they are seen as hindrance, and the student call them they are referred to as white clogs clogging the corridors, right? So, however, the student goes on to highlight that the students don't suddenly become doctors. It's a gradual process, and thus the students should be accorded the same understanding in their education. This is especially apparent during their housemanship or internship, where the students suddenly treated with respect, understanding by patients, nurses, etc. So I think the main thing that he was trying to get across is that during their medical school, during their clinical training, they're like, wallpaper. They hardly get involved. And sometimes it's a hit and miss if the attending physician takes a class or not. However, once we saw this, we immediately changed in our curriculum, and this came out in 2012. We revamped the curriculum. We actually are now embedding students into the care teams so they get the first-hand training as well. So we see the same thing in many different settings. From undergraduate to residence to fellowship, even to the continuous professional development, CPD, CME training. Right? There's some issue with the way that we design. We are not embedding them, we are not empowering them, we are not supervising them closely to develop these basic clinical skill sets, whether they are in the undergraduate setting, residency setting, fellowship setting, or as a practitioner for their accreditation and recertification. So one of the key areas is that the focus is not the developmental part. It's more or less our clinical curricula is a hit and miss approach. However, they learn a lot. They're supposed to learn so many other things within this. And we are kind of, I feel, losing the touch or the focus on the developing those basic clinical skills and the basic clinical knowledge. The time on practice has reduced greatly. If you really look at it, I'm not talking about they are just the wallpaper kind, looking at patients and just following the physician, but actually part of the team providing that care. There's very little longitudinal supervision, longitudinal mentorship of the student from the basic science years all the way up to the graduation. There's no longitudinal continuity of the curriculum, and also there's no longitudinal continuity of patient care because of this. And of course, the assessment part is not aligned very often, and again, it is a hit and miss thing to the basic clinical skills and knowledge. Well, if that is the case, how should we prepare our students for the future? Well, I say that we should first prepare our teachers, because Professor Ronhard once shared at the 6th Asia Pacific Medical Education Conference, there's no such thing as curriculum development, only faculty or staff development. So I think we need to really focus our faculty and try to get them involved, to train them, to rethink on how best to develop a learner-conducive, learner-centered curriculum. And to do this, we need to also look at the way our students are learning now, because they are now not the same as when we were students. So how do we engage and how do we empower them? There's no magic pill. Well, we need to focus on building that trust with them. We need to make their learning relevant and purposeful. We have to get our students and challenge our students to think out of the box, because it is not spoon feeding. We need to innovate in our own teaching learning, and they need to be partners and co-create this learning environment. And of course, we need to move away from what Ron Harden mentioned, the fog approach, the presumptions, hunches, opinions, and guesses, but use the best evidence medical education approaches to train, to develop a training curriculum so that the focus is on developing their basic clinical skills. So with that, I'm happy to share that some of our work here, we have moved away from these large classrooms to more smaller, focused student interactive sessions for their knowledge gain, in clinical knowledge gain. And also the curriculum has been changed from the basic science years, using technology in the initial formative years to bring the relevance of their clinical learning later on. But however, gradually exposing them from these simulated environments, augmented environments to actual clinical practice, and making them part and parcel of the care team during the clinical years, when they are in the clinical years, to work with the clinical care teams. So it's a process which you should start from the very beginning and then slowly ramp it up in the clinical years to actually to give them the hands-on skill sets to get involved in patient care with the other care providers. And this is basically what we said of putting into practice the principles of embedding medical students into care teams. So in summary, I think the most important thing is that we need to actually work with our students. The faculty, we need to train faculty. The faculty need to gain trust in these new millennials, Gen Zs. We need to co-create the curriculum with the stakeholders and focus on the continuum of supervision, continuum of care, and the continuum of the curriculum. We have to establish more longitudinal mentoring and supervision programs and inculcate the practice environment into this curriculum. We need to design the assessment, and the assessment should be longitudinal. And of course, we now have a nice structure called the programmatic assessment shared by Kees van der Looten and Lambert Schwartz. We need to look at how can we actually leverage on those learnings and also inculcate the curiosity and engage in quality improvement of our curriculum. So I think there are more questions to reflect than fast solutions to provide. And so with that, I think the most important thing is that we ourselves need to adapt to change. We need to be flexible and we need to be innovative and we need to go back to basics. So with that, I want to thank Professor Henry Yang and also the Changhua Christian Hospital organizing team of this conference. And we look forward to seeing all of you at the Asia Pacific Medical Education Conference next year in January in Kuala Lumpur, and hopefully in Kuala Lumpur or as a hybrid conference. With that, thank you very much.
Okay, very thank you to Dr. Dujiba. And hello, Dr. Dujiba. Thank you for your wonderful talk.
Thanks.
And it's my pleasure to see you online. And yeah, welcome.
Thank you very much. It's my honor to be part of the celebrations. Thank you for inviting me, Professor Yan.
Okay, and thank you for giving us a very provocating topic, rethinking the medical education, particularly in the COVID-19 era. I think go back to last year, the COVID-19 gave the whole world a panic. So many, particularly the clinical education, clinical training, almost disrupt in every country. So, and first of all, I would like to congratulate the Singapore, your government and the whole country have a very wonderful performance in dealing with the COVID-19 from the prevention and vaccination, and rank a very high standard. So First of all, can you share that in Yongluri Medical School, how to prepare and how to deal with the COVID-19, particularly in the change of the medical education in Yongluri Medical School? Thank you.
Thank you, Professor Yang. So the COVID-19, as you said, starting from 2020, early 2020 to now, there have been several changes that has happened. And as we quite rightly pointed out, just like Taiwan, Singapore rapidly adapted, and we are still evolving. Even last week, we are discussing on how best to change, etc. So until the recent changes, I will share with you what are the very latest changes. But most of the changes last year and most of this year, we have actually compiled, and thankfully it was published in Academic Medicine. I will send you the link so that you can share with the others, and also in Medical Teacher, how as an academic health center we rapidly adapted, and the lessons learned. So I will send you the link so you can share. But the latest changes, as I shared, is in the clinical years. So one of the key things that in my presentation is that I was very careful not to give solutions. So come out and say that this is the best way, kind of to mitigate, to avoid even during pandemic the loss of basic clinical skills, because I strongly believe that this has to be co-created based on a framework. My good friend and colleague, Dr. Eric Combo, shared in his presentation those theories and framework that actually helps us to conceptualize and co-create our work. But what we did, how we co-created our training curriculum, is that we decided that because of the movement restrictions, and also that the government placed restrictions where our students couldn't move from one cluster of hospitals to another, because previously students rotate during their clerkships from one hospital to another, but that was stopped by the government or the Ministry of Health and Education guidelines. So what we did was that we changed the clerkships to what we call campus-based learning and clinical components. So say, for example, if the clerkship is 10 weeks, let's say medicine clerkship, the first 2 weeks where the students, they come to and we train the entire cohort, the basic clinical skills, the basic how to do a physical examination, how to do basic clinical procedures, what are the core clinical conditions that can go wrong, etc. in our Center for Healthcare Simulation, using standardized patients, using moulages, etc. And then after that, the students are sent to specific hospitals with the focused training in certain areas where they actually are exposed with supervision to those core clinical cases, and also get trained in those core clinical procedures. Because this is important. I just want to share one story, because I think that's important, because what in our setting, what we realized was also, I mean, this was happening even prior to COVID, because in Singapore, we increased our nurses training cohort. Previously, Singapore was dependent a lot on foreign nurses coming from the region, Philippines and other places. But the government decided that we need to train our own nurses. So we increased our nurses training capacity. And because of that, our medical students have now less opportunity to do some basic clinical skills like drawing blood, etc. But when they are practicing young doctors, when the nurses fail to even draw blood from a collapsed vein or whatever, they call the junior doctor. Now, if we don't train them in the basic training with all these, how to draw blood, even from a collapsed vein, when a patient collapsed and the veins are not visible, and they will struggle when the nurses call them, who are much better trained in drawing blood when they can't. So things like that we have now incorporated into the clinical training despite the COVID situation.
Thank you for your very precious sharing. And I think maybe I will mention another issue that just a few months ago, I have the opportunity to communicate with Professor Janet Grant, from UK.
Yes.
Yeah, she described the response, for example, the online meeting, virtual conference, or virtual lecture. So I think she described it as like a firefighting response. So just you mentioned we should go back to the basics. So how to make sure or to do the quality assurance of the medical education? Can you share your experiences about this point? Thank you.
Sure. So I just want a quick clarification. You want the quality assurance processes in our medical school or in general? Because I wear the multiple hat of being in the WFME also, in the Executive Council. So do you want me to share in Singapore or in general?
Mm-hmm. Okay.
Is it Singapore that you want me to share about how we do the quality assurance, or?
Okay.
Sorry. Okay, so sorry for confusing you, but I will very quickly share what's happening in Singapore with regard to undergraduate quality assurance, because the residency training, as you know, my good friend Eric will share, we conform to the ACGMEI standards, but in undergraduate, the 3 medical schools in Singapore, we have developed a quality framework which is based on the WFME basic medical education, and the quality assurance process is managed by the Singapore Medical Council and the Ministry of Health, a combined task force that has been set up. But it is under the auspices of the Ministry of Health and also the regulator, Singapore Medical Council.
Okay. And thank you again. Thank you very much, Jiba. Because the time constraint, the time is always not enough. So see you and welcome. Maybe in the next time you can come to Taiwan and in person to communicate everyone and to the Taiwan's audience and your friends here.
Absolutely.
Okay.
Thank you very much. Thank you.
Thank you very much. Thank you very much. Bye-bye.
Bye.
Thank you.
谢谢杨医师的
Thank
主
you,
持。
Dr. Yang's moderation, as well as Dr. Duchiba's excellent presentation. Next, I would like to invite the next moderator, that is Dr. Qing-San Liu, who is a Vice Superintendent of CCH, who is also Cardio and Vascular, as well as the Genomic Center's Director. He received the Ph.D. in US and conduct medical research as well as clinical service, and also publish numerous articles in various journals. Without further ado, let me pass the baton to Dr. Liu to introduce the speaker.
Yeah, good morning and good evening in state. So it's my pleasure to introduce the follow talk and the speaker. And we know that in the recent 2 years is a great impact for the medical education, not only in the college, also in the hospital training. So the Professor Hong is a department of the family doctor, and his training is from the Harvard University for the undergraduate, and also to receive the medical training system in the UPenn, and follow with the Ph.D. program in the University of the Ulster. So it's a very comprehensive and a very wonderful experience in the academic and the practice the training for the medical education. And also he returned to the Taiwan University and give the help for the medical education, for the innovation, and also have the very, very good suggestion for the planning or training in the different culture. And now he is a professor in the Georgetown University, and he just hosts the Center for the Innovation and the Leadership in the medical training program. So he had sharing the study for the different kind of the impact with the leadership in the different country and culture. And his topic is for the he will share his presentation with a different kind of the adaptation for the dean and clinical practice for the teacher. So welcome, Professor Ho.
Hello， 不好意思，你们可以听得到我说话吗？
Can you hear me? Yes, yes, okay. So, all right. So I'm going to share my slide. However, I have difficulty. Is it possible to have someone to help me out? Is it possible to have someone to present my slides? Let me try again. Can you see my slides? Yes, yes. All right. So this is from my side, right? Yes, yes. All right. So, all right. Can you see my slides? Yes. Okay, right. I'm sorry. Yes.
To give this talk. I'm going to talk about a study that is a SWOT analysis of medical school adaptations to COVID-19. It's a cross-cultural, cross-national survey of deans in Italy, Japan, Korea, and Taiwan.你们看得到那个简报，就是有到下一页。
Can you show my slide the next stage? Or...
All right. So COVID-19 outbreak in Wuhan, China at the end of December 2019 evolved rapidly into a global pandemic and upended almost every aspect of our lives, including medical school adaptations across the world. There is a growing literature on how to transition medical education online. Medical education associations also developed websites and offered webinars to share best practices and innovations, but most of those focused on online education. The literature reflects the important perspectives of teachers and students with voices from medical school leadership, and the evaluations of these adaptations relatively limited. Furthermore, most of the publications are based on lessons learned from single institutions in English-speaking countries. As non-English speaking countries encountered COVID-19 and started to reopen medical schools earlier than English-speaking countries, lessons from non-English speaking countries can be valuable to the global medical education community. And cross-national studies could also offer more generalizable findings. So, we designed a study to address the gaps in literature by surveying medical school deans in 4 countries on how they adapted their curricula amid this historical moment. The 4 countries included in the study are Italy, Japan, Korea, and Taiwan. I will briefly describe the context of these countries according to alphabetic orders.
First, Italy has been severely affected by the COVID-19 pandemic. You probably recall seeing news in March 2020 that the medical needs exceeded the Italian healthcare system capacity. Physicians had to make difficult decisions such as removing respirators from elderly patients in order to resuscitate younger patients. And health providers themselves accounted for 9% of total COVID-19 cases. A series of governmental decrees impacted medical education in Italy. On March 8, 2020, a decree by the Italian government imposed a nearly complete lockdown of the country. This decree ordered the suspension of all on-campus activities. For medical students, the decree led to the substitution of clinical clerkship with distance education activities. Another decree on May 5th, 2020 began the so-called phase 2 living with the virus and allowed a partial resumption of clinical clerkships while requiring face masks and social distancing practices. Phase 3, restarting Italy, began on June 15, 2020, allowed further relaxation of restrictions permitting in-person lectures and exams, usually with a reduced number of available seats to maintain social distance. So distance education continued to be allowed as an alternative to on-campus education. We surveyed the directors of medical schools after phase 2. In terms of medical education in Italy, all Italian medical schools offer a 6-year curriculum leading to an MD degree, and they share a core curriculum and learning outcomes to meet the requirements of the national structure and the norms of the European Union for acknowledgement of an MD degree. The admission to medical school is achieved with a national test that distributed students across the whole country. Hence, in most Italian medical schools, a large number of students are not from the town in which the school is located. The director of a medical school is responsible for overseeing course design, teaching activities, evaluation, and quality assurance. The directors convene a council of faculty members and serve as leaders to foster excellence and innovation. All the directors meet 4 times a year in an association, and they play very important roles in Italian medical schools' adaptations to COVID-19. In terms of the context of Japan, Japan's first domestic infection was confirmed on January 15th. On April 7, a state of emergency was declared for certain areas of Japan and expanded to cover the whole country on April 16th. So under this circumstance, the general guidelines for COVID-19 countermeasures developed by the Japanese Ministry of Education, Culture, Sports, Science, and Technology were sent to all higher education institutions on June 5th, 2020. The advice was very general that colleges should operate in a resilient manner based on the guidelines. However, they didn't address the special nature of medicine and its experiential educational practices, such as clinical clerkships, anatomy practices, and OSCE exams. So the situation in Japan required medical college leaders take actions within their local context. And most of Japanese medical schools canceled or suspended clinical clerkships, and some implemented remote education for medical students during the time we conducted the survey. In Korea, the impact of COVID-19 on medical education is similar, except that they continued face-to-face clinical clerkships in hospitals with an average of 3-week postponement. Students' safety was ensured in part by the full provision of personal protection equipment. Curricular adaptations to online education settled speedily, and most students swiftly adapted to online learning and showed higher satisfaction level than expected. The context of Taiwanese medical education during COVID-19 is very familiar to this audience, so I won't describe in details. In short, Taiwan was one of the few countries in the world with no lockdown in 2020. Medical schools continued campus-based, work-based medical education. With collaborators in Italy, Japan, and Korea, we designed the cross-national survey of medical school deans to address these research questions. What curricular adaptations have been made in response to COVID-19 pandemic? What were the strengths, weaknesses, opportunities, and threats of the curricular adaptations? What are the lessons learned to be applied to the future? We conducted an online survey by Google Form to explore Italian, Japanese, Korean, and Taiwanese deans' perspectives on curricular adaptations between April and June 2020. The survey questions were developed based on a review of relevant literature and consultations with international collaborators. We adopted open-ended questions to allow for diverse responses from all medical schools participating in the study. Surveys were distributed to all medical school deans in the 4 countries. Participation was voluntary without incentives offered. Following the initial email, we periodically sent reminders. The free text responses to open-ended questions in the survey were analyzed by the researchers using a qualitative thematic analysis approach. One researcher identified themes that emerged from the qualitative data. Then a second researcher determined if they agree or disagree with the analysis. For each point of disagreement, the 2 researchers discussed the data and reached consensus. Data analysis was initially inductive. After the themes emerged, we used a SWOT analysis framework to group the themes. We use a SWOT analysis framework to group themes into 4 categories: strengths internal to the institution, weakness internal to the institution, opportunities external to the institution, and threats external to the institution. We chose the SWOT analysis framework because it explored not only facilitators, but also barriers, not only internal, but also external opportunities and threats in the environment. SWOT analysis has been applied widely to evaluate program performance and to identify future strategies, especially in business and increasingly more in medical education. Now let's look at the results of the study. The response rates of the surveys are 33% for Italy, 58.5% for Japan, 92.5% for Korea, and 100% for Taiwan. Although the response rates in Italy and Japan are limited, medical schools from different geographical regions were represented, and we did not observe any difference in the responses among different geographical regions. Medical schools in all 4 countries rapidly adapted curricula according to local government and hospital policies. Creative adaptations to in-person assessments were reported to adhere to policies and maintain social distance. This is a table summarizing the SWOT analysis. Let's first look at the similarities in the strengths reported by the deans. Those include rapid curricular adaptations, rapid infection control measures, and collaboration with students. For example, an Italian dean wrote, we were able to transfer the in-person lessons, practice, and clinical activities into online activities within 1 week in order not to waste time for students. Next, in terms of common weaknesses reported by deans across the countries include lack of faculty readiness in online education, limited human resources, and limited clinical clerkships. For example, a Japanese dean noted there is an issue of increasing the workload of administrative staff due to the change in classroom format and securing a temporary budget for equipment and other expenses. In terms of opportunities reported, those are innovations in education, interinstitutional collaboration, and centralized anti-epidemic policies. For example, a Taiwanese dean reported, I've been advocating for flipped classroom for years without much success. We accomplished this transformation within a week in response to COVID-19 pandemic. Threats reported by deans across 4 countries are hospital infection control measures, limiting students' clinical activities, IT support for online education, and relationship with stakeholders. For example, a Korean dean stated, medical education is not only conveying medical knowledge, there must be a rapport built through face-to-face education, but it is hindered by the current social distancing. In addition to similarities, we also found some differences in adaptations to COVID-19 across countries. The major one is the different stakeholders the deans have considered. Interestingly, but not surprisingly, stakeholders in Asian countries include parents, but not in Italy. These differences may be explained according to Hofstede's model of national culture, which consists of 6 dimensions shown here. Italy scores high in individualism. In contrast, Japan, Korea, and Taiwan score lower. These collectivist countries are more inclusive of social networks, which could explain why parents' opinions are taken into consideration in medical schools' adaptations to COVID-19 by these medical school deans. Another cross-national difference is the expectation of the future of medical education. While most deans reported that they would like to continue integrating online education in the future, a number of Italian deans expressed the desire to return to the way medical education was conducted before COVID. Another dimension in Hofstede's model, the long-term orientation, might explain this difference. You can see that Japan, Korea, Taiwan score higher in long-term orientation, meaning they are pragmatic, taking the long-term change into consideration instead of sticking to short-term historical norms. So medical school leaders in these countries might embrace change more readily than leaders in Italy. And another interesting dimension is masculinity. So Japan scores very high in masculinity, which means the cultural values being competitive and tough, as opposed to countries which prioritize femininity values of being cooperative and tender. This cultural dimension might explain the lack of a clear central government policies for medical schools, leaving medical schools to make tough decisions on their own. So in conclusion, this cross-national study offers a conceptual advance by illustrating how SWOT analysis can help us to reflect on medical education's adaptations to COVID-19. Our analysis of strengths, weakness, opportunity, and threat of medical schools adaptations across 4 countries highlights some common strategies that we can leverage these strengths and opportunities to overcome weaknesses and threats. In addition, this study demonstrates that medical education leaders have to consider national cultures in leading curricular reforms. With international studies like the one I just reported, and with international conferences like this one we are in, I believe that we as an international medical education community could collaborate to apply lessons learned from adaptations to COVID to better medical education in the future. I wish to acknowledge these international research collaborators and all the deans who took time to answer our surveys. Please feel free to contact me if you have any comments, questions, or ideas for collaboration.
Thank you, Professor Ho. Yeah, it's wonderful the study in here to provide information to all the official government education. So give some of the policies in the national wise, even the international wise. How the or maybe you have the one interesting about why did you to recruit the dean from the state or the UK?
I didn't conduct the study because I heard that there are many surveys going on and people are all very survey fatigued in the US, and there are over 100 medical schools, so it's very hard to do that, and they are all very busy trying to figure out how to do things, and I felt that in Asia and Italy we experienced COVID first. Yeah. And so when we conducted the study, most of the US and UK were kind of pausing, okay. Not doing much. Yeah, so I was hoping that us these countries which experience COVID first can offer some advice, and can share experiences.
Yeah, we look forward. Yeah, and another question about it is a very interesting. If the vaccine, the program is complete before go to the clinical clerkship, so it's a different confidence and the safety for the consideration for the tutor. So you suppose if we give the full vaccination program before the clinical or even to the college, so it can change we call it the medical education policy can be changed or maybe can be modified more to increase the face-to-face, even the more the clinical skill training program, or maybe more complicated, maybe comprehension. Yeah.
Yeah. Well, from what I observe here in the US, that's the case. So I think, with the vaccine, and it's a requirement for example, for Georgetown University, not just the medical school. Mm-hmm. So actually 98% of our students and 98% of the faculty members and 97% of the staff are all vaccinated. Okay. And so I think that, it's easier and people feel more comfortable with in-person education nowadays. It's definitely a game changer. But I have to say that the survey we did was very early during the pandemic last year, in April, between April and June before the vaccines were available. Yeah, so I think it will be very interesting to do like a follow-up survey now to see, like what the leaders are considering now. Yeah, and I think, as you said, the vaccine would be the capacity of vaccination would be a big factor.
I suppose maybe good news for the medical doctor or the medical student, and also his parent almost can relax for his children at the training program in the hospital. One of your interesting finding is we have to provide inter-institute medical training resource. So it's very, very interesting about if we can provide international-wise medical resource from the IT system, because maybe some kind of the region did not have such high quality AI or AT system, so IT system. So it can be sharing from the international-wise or international-wise.
Yeah, I think that's a great idea. Yeah, yeah, definitely. Yeah, I think that in some of the organizations are doing that, like compiling resources and sharing the resources. Like the big like American like associations like the AAMC, like has like resources available online for everyone to use. But in terms of like how to do things in terms of the IT part, it's still like limited, like by like every country has different capacities. But in terms of the like how to teach and kind of the content of teaching, there is a lot of resources available. And even the medical education journals, have like compiled resources.
Thank you.
I haven't checked ACGME. Maybe Eric can comment.
Maybe
I think AMA has like a good resource page as well.
Thank you. So because the time limit, and also thank for your during the evening give all the talk and sharing to the people international wise and in Taiwan. And finally, thank you your talk, and hope we can see soon in Taiwan. Okay.
I hope so.
Thank you.
Thank you.
Thank you.
Bye.
Thank you. And bye.
谢谢刘副院长的
Thank you, Dr. Liu and Dr. He. Next, we are going to convene the last section of this morning. The moderator is Dr. Chen Shuzhen from CCH, who is the director of a nursing department. She graduated from Michigan University with a master's degree and also received a Ph.D. degree at the Kaohsiung Medical University. Without further ado, let me pass the baton to Dr. Zhang to introduce the speaker. Distinguished guests and ladies and gentlemen, good morning. After three excellent presentations, so from the medical perspective, we are very honored to invite Dr. Xi, who is a nursing practitioner who serves as the faculty at the Department of Nursing, National Changhua University, who is the president of Taiwan Association of Nursing Education. So she holds multiple positions and dedicated on the females, the health and maternal health and obstetric care. And today, she will start from a professional nursing expert to talk about the challenges and the transformation of medical education during the COVID-19 pandemic era. Through her experience and sharing today, she is also going to recommend the education of nursing with the charge and also some technologies to find a new opportunity. Without further ado, let's pass the baton to the Professor Xi. Her title is The Challenge and Transformation of Medical Education During the COVID-19 Pandemic. Dr. Chen, Dr. Chang, and Dr. Gao, ladies and gentlemen, good morning. First of all, congratulate CCH on your 125th the anniversary. I really very appreciate this opportunity because my nursing background, I will focus on the perspective of nursing educator, and also I'm open for your accommodation. This is the outline of my presentation. First, I will cover the medical education challenge under the COVID-19 pandemic and also the transformation opportunities in medical education. I think this pandemic, the greatest impact to us as an educator is that in the close of the school, there's the articles from the government's decision from May 19 to May 28th, the 2 weeks shutdown of all the campus. But however, it extended to 3 to 4 months until the beginning of this month. Some of the campus are opened. Do you know that once the school closed, in how many students are impacted? Here in Taiwan, a total of 4.2 million students study at the diverse levels of schools. Among them, about 1.2 million students in colleges. Therefore, when the campus is closed, the medical education received a significant challenge. First challenge is that the emergency remote learning. So in order to meet the objective of the closed campus, but not the curriculums. So with remote learning, it is a part of the pedagogy to transform from the classroom education to the online education. However, not all the faculties are ready, not to mention about the resources. So because of familiar with online learning using various platforms, so either it's simultaneous or consecutive, they all were very frustrated. For example, the first time I used the web education. However, I'm using another more familiar with another platform, so I have some learning period. I remember one time the school asked us to record the teaching and upload it, but I did remember I have clicked the record. However, when I upload the file to the cloud, it was overloaded. So I was very frustrated because I was not successfully uploading. So the other challenge is that between the traditional education versus the remote education, there's a debate that they consider remote education is just transient. The traditional education should not be replaced in the long term. So, however, when we prolong this remote education, then the interaction between the mentor and students will be interrupted. On top of that, for remote education, the students might have some downgrade the value of higher education. Certain students even claim that it doesn't worth the tuition. So our other concern came from that our educators, whether our educators are ready for this remote education, whether the school can provide technical supportive teams, including the software and the hardware. We're also concerned about students' learning attitude, whether they can maintain their self-discipline and to study and what is the learning environment at home. So on top of that, the traditional education have one challenge, that is how to make assessment about this remote education. The other education came from medical education. Many healthcare related courses have the clinical learning. So our challenge came from that, whether we need to sustain the clinical practice. So as an educator, we really care about under COVID-19 the students' safety, and also we also care about the students, whether the students can continue their clinical practice, because the clinical practice is a very critical course. It provides the students to the necessity to take the bar exam. So it also provides opportunity to advance their skill, and also provide the students interaction with the patients. During the COVID-19, we also heard that some of the advocacy to close this internship because of the capacity from the hospital are reduced. So sometimes they close their service. In this May, our students were not vaccinated, so they were not ready. So when they have some risk in terms of their safety, and so we also during the high peak, we also worry about whether our students will get infected, because they might carry the virus back home. And many parents also call us to ask us to terminate this clinical practice because they have concern about the safety of their children. Another challenge came from the license and the employment after they graduated. Each year, Taiwan will have different license examination at the end of July. So during the pandemic, we were concerning about whether we want to postpone the license examination, or will that impact to the employment opportunity for those students. And also, it's like nursing department, so their clinical practice were terminated. So whether their competence will be trained. So if not, then so how we compensate those gap. And on top of that, when the student graduate from the school, will their employment opportunity being influenced? So that cause the hesitation of the students' dedication in the healthcare industry. We also saw some social issues because of the COVID-19. We had some inequality. So certain parents they lost their job because of COVID. So it will impact the students' learning at home. For example, I have one student who told me that, "Do you know why I want to stay in the campus? Why don't you go home?" He told me, "My parents run a small food stand, but if I go home, I don't have a desk because our parents cannot afford to purchase a good notebook or have internet access at home. So because my parents have lower social and economic status, so we also have international students who came from Vietnam and Indonesia. So they will have some hardware issues if they want to study at home." So that is the World Bank also published an article in 2021. It says students from socio-economically advantaged family receive more parental support with their studies during the school closed period. And also the mental health is something we cannot ignore, because it is virus-induced uncertainty, as well as the daily routine changes during the lockdown period. And another large scale international survey reported that out of close to 1,000 the interviewees, about 10% say they have a mild mental distress, and 50% receive moderate stress. So this because it's relevant to the access to the provisions, and also they have claimed some of the positive the mental status. They also found that is relevant to their social support, education level, and the psychosocial flexibility. So in the university, we also have some financial shortfall. In UK, actually, international students contribute a large portion, about 7 billion incomes. Last year in US, they have the 25% reduction of the foreign students. And also when the campus is closed, there are auxiliary revenues are cut for accommodations, catering, bookstores. Many university host summer camps and conference. Those incomes are gone. So because sometimes the university will receive funding from enterprises or charities, and so during the COVID-19 pandemic, the funds are significantly reduced, or donations are gone. So many of the scholarship came from the donation. So it also was suffered. With regard to the international mobility, also increased or decreased, especially during the international conference and meeting are cut or shut, and also overseas learning exchange programs are terminated. International students are very hesitant to study in overseas. For example, in Changhua University, in our nursing school, we also have international courses. Last year, we have about 40% of the students postpone their registration or drop out permanently. In university, there's one issue, that is the grant, the study grant, the funding or imbalance in research projects. So we are very concerned. Many researchers found out that if your research is relevant to COVID-19 or relevant to medicine and life science, it is easy to receive the grant. Next, I'm going to talk about possible transformation opportunities during COVID-19 pandemic. So under COVID-19 pandemic, what are the areas we can transform, or are there paradigms and resilience? First is education paradigm shift. In the past, we were focused on so-called knowledge and technology and the pedagogy. For example, we highlight the knowledge convey, how to use appropriate, effective strategy and pedagogy, and also we will make necessary assessment. After the pandemic, we not only maintain the knowledge and paradigm, we also incorporate technology, epidemiology, and psychology content. Meaning that in the future, with our medical education, we should add the technology on top of traditional education. So with regard to the medical education, we will consider the COVID-19 parameters, and also because of the pandemic, many faculties and students have some physical impairs. So psychologically, we also need to care about their mental status. So as I mentioned earlier, that the remote education is kind of a transient and urgent. However, in the future, this remote education should be in long-term intention. So we need to know that how to effectively use the online teaching. and also provide more organized teaching. So the school should not only provide the hardware, but also will help the students to conduct remote education. On top of that, the teachers need to know more about how to apply remote education, because the students came from Y generation and Z generations, so they focus on the interaction, especially the Z education. They also are looking for a practical learning. So if you can apply the online education, if that is a norm, how to adapt and attract our students under the COVID-19. Another the issues that the triage concept.
Triage concept comes from medical field, especially at the emergency service. We use triage concept to decide which patient will be treated first. The same goes for pandemic response. We need to think about what must continue to be intact no matter what can be postponed, what can be adapted, changed, or remediated, what can be dropped or minimized, what needs to be added. So the triage concept includes what, how, impact, implementation, and evaluation. Amid the pandemic, we also talked about the resilience. Resilience refers to the positive momentum to recover. We can also apply resilience in curriculum planning, redesign, redirect, reschedule, reconfigure. I would like to share with you one example on resilience on clinical practicum. This is Professor Zhong Shu-Hua. I would like to share with you her story. She's currently teaching at Department of Nursing, Zhongshan Medical University. On day 3 of the practicum class, she received a notification that the class should be suspended, but there are still 15 days to go. So she thought that maybe she would use the first 3 days to think about what she should do. And also for the 3 days, students can go back home. So she planned online teaching. How can a practicum class be performed online? She thought that was very challenging, so she had to reschedule and redesign the course. So students were asked to find one of the family members to assess their physical conditions. And students will find the grandmom, as shown in the picture, the upper left corner. And she found that her grandmom had edema and also some constipation and also some pain. And Professor Zhong also used software to do online demo. Students were very creative. For example, this is the IV set. This is actually homemade IV set. They were so creative. They just use the cleaning gear, use a port to serve as the IV pole. Resilience can also be applied to research. While we thought about should I continue my research, sometimes we need to suspend our study because of the restriction measures taken by the hospitals or because of the lockdown, the policy. So maybe we can reschedule our research projects, or maybe we can change the priorities. We can redirect the research focus on topics. Other than that, we also think about how the interdisciplinary team can work together in teaching. We have faculties from different disciplines to work together to plan a program to teach students from different departments. For example, the April this year, I worked with 2 professors from engineering department to plan the program applying design thinking. We build app to conduct maternal child nursing health education. Teachers from disciplines provide different perspectives to accomplish this mission impossible. We can also use that in our interdisciplinary research. Research, communication, collaboration, leadership can be developed through such a process. Interdisciplinary research can cover many of the sustainable development goals, for example, hunger, poverty, health, the international collaboration on achieving SDG goals of the United Nations. Amid the pandemic, we can also think about how we can fulfill our impact in the community. You can see that we have domestic and international nursing students working together to help translate a lot of anti-pandemic policy and measures, including these languages in Southeast Asia. We are creating a boundarless opportunity. It is very expensive to arrange an opportunity for international speakers to visit Taiwan to give a talk or even to teach in Taiwan. It's not practical for them to fly 18 hours to come to Taiwan to teach 4 hours. Now, we can use an online platform. We can use online tools to have these international lecturers to teach or to join us at virtual conferences. So that opens more virtual international mobilities and collaboration opportunities. I also teach some Thai students. In the past, they had to come to Taiwan for 6 weeks, but now we can do this online. I also think a great opportunity is to organize virtual international conferences. We can also have a virtual recruitment of international students, and we can conduct a virtual exchange program of students. A very good example is the international online conference we have today. We should take advantage of these virtual conferences to learn from international experts. I also like to talk about carrying pedagogy in practice. It is not a new concept. It has been talked about and applied for a long time. At this point in time, this is even more important. This is a student-centered learning environment, and to have faculty and students engage in dialogue through shared experiences and interactions. Virtual international mobility is the future trend. we can have more internationalization from home. I work with a university in Thailand. I'm actually teaching some Ph.D. students on their dissertation. Now I can meet them online once every week. We also organize online conferences. We recruit students online, and we also organize summer camps. This is the caring pedagogy in practice. Caring pedagogy, I just told about, is a student-centered learning environment. Faculty and students engage in dialogue through shared experiences, interpretation, reflection, and problem solving. One of my students is teaching at a nursing school. She shared with me her philosophy. Online courses will shed some light on the importance of interaction in person between people. So she asked herself two questions. How can I maintain the same passion and empathy even when I'm teaching online? How can I attract the attention of the students? Last but not least, I would like to share with you this point. In the past, when we meet our colleagues or friends, we will ask, how are you? But now we ask two questions. The first question is, have you been vaccinated? And second, what's your new normal in your life? So this is a question also for everybody. From the morning session until now, you have listened to the presentation. I think you have the image about the new normal. You can use the concept to define your new normal by yourself in your life and also in medical education. This is my summary. I think you must have read this book, A Tale of Two Cities by Charles Dickens. Allow me to conclude my presentation with these passages. I really like what he said here. It was the best of time, it was the worst of time. It was the age of wisdom, it was the age of foolishness. It was the apple of belief, it was the apple of incredulity. It was the season of light, it was the season of darkness. It was the spring of hope, it was the winter of despair. We have everything before us, we have nothing before us. We're all going direct to heaven. We are all going direct the other way. Thank you very much for your attention. Thank you very much, Professor Shi, for sharing with us a lot of information within a very short period of time. And of course, as educators, there's a lot that we need to adapt. A lot of questions we need to think about, teaching, research, even cross-country research. Any participants have questions for Professor Shi? We have many young participants. They may be clinicians, they may be educators. So could you talk about more about your personal experiences, the biggest challenge you are facing, and how do you overcome the challenge? In your presentation, the message seems to be it is a crisis, but it is also an opportunity. So could you talk about, based on your experiences for so many years, the biggest challenge you have been facing, and how did you overcome the challenge? Thank you. Thank you very much for the question. As Director Zhang just indicated, the crisis is also opportunity. In the past, we did not put into efforts on the online teaching. In early days of the pandemic, I did have some frustration because you have to know different online teaching platforms, and it was a process of trial and error process. You just have to be more open-minded to talk to people who know more about these platforms. For example, my presentation today, I had to learn how to record the video. I tried several times. It did not work well, so I had to consult other people who know how to do it well. So it is a collaboration process. As I said in the very last part of my presentation, we need to collaborate with our students. If they are Generation Z, they know smartphones very well. They know technology better. We need to care for them, and we also learn from them. So it is a collaboration process. I told about we have recruitment campaign online. There's a lot we can do virtually, but let me say that the virtual interaction cannot replace in-person interaction. If time permits, the policy permits, we should also include in-person interaction. We have a question online. The question is, in virtual practicum course, how can you teach and perfect the clinical skills of the nursing students? Speaking of the virtual teaching, we need to set their learning goals, objectives. We can play the video, some demonstration of how work is done. So they will study, watch the video first, as Professor Zhong, the example I just gave. The students can film their practicum process at home and they make the video and they share the video, have discussion online. Well, the best way is to have the in-person practicum, of course. Indeed, from your sharing, we know that the virtual alternative is a last resort, but for clinical work, it is human interaction. It is always better to have in-person practicum course. But sometimes we have to make compromises. There's prepare for the worst, but hope for the best. Because we still need to weather this crisis, this pandemic. As educators, we face students daily. We see hopes from them. I think that's a very important message to us all. Well, if we work hard, I think in the future, we will have this time to celebrate our harvest. Well, there's a super typhoon approaching Taiwan. But I think after the storm, we will see beautiful rainbow. We will weather the pandemic. We will weather the super typhoon. Thank you very much for your participation. So that was the morning session. And to the teamwork collaboration, And through our experiences sharing, we know what we are doing is very important. Everybody is special. We are living in a special time. We remember the past, we live in the present, and we hope for the best in the future. Thank you very much, Professor Shi. Let's give a round of applause to thank you, Professor Shi. Thank you. That concludes our morning session. Thank you, Director Shu Zhen and Professor Shi. That concludes the morning session. To the online participants, please sign out. First, in the afternoon, we will come back at 1:30. And at 1 o'clock, the sign-in is open. I'd like to remind you, after the afternoon session, you need to sign out and fill out the survey to get your credit. And we also have a test after today's conference. Thank you very much. We'll see you in the afternoon. Thank you.